Assalamu alaikum wa rahmatullah. This talk about bronchoscopic cryotherapy and transbronchial lung cryobiopsy. Let's start with the effect of low temperature and freezing in the airway mucosal layer. Effect of mild lower temperature, which is less than 15 centigrade, lead to extracellular crystal formation and efflux of the intracellular fluid, which result in cellular dehydration and toxic increase in intracellular electrolyte concentration. And when temperature become most lower than this, that less than minus 15 and up to minus 49 centigrade, it will lead to formation of intracellular crystals, causing a lysis of intracellular organelle and cell death. Complete crystallization occurs when temperature becomes lowest than minus 50 centigrade. The material used as a cooling agent are called cryogen. The cryogens used for bronchoscopic applications include liquid nitrogen and nitrous oxide. The nitrous oxide is the most common employed cryogen. Nitrous oxide, widely used coolant, are stored at room temperature under high pressure in liquid phase. The passage of the liquid through probe from high pressure to atmospheric pressure causes it to expand, that resulting in a temperature of minus 89 centigrade at the tip of the probe, which lead to complete crystallization of the tissue attached to the probe. The cryotherapy machine consists of three parts: the console that regulates the flow of cryogen by controlled via foot pedal, and a gas cylinder with connecting transfer line to the console, and a cryoprobe for delivering controlled coolant to the lung tissue. There is several companies manufacturing the cryotherapy machines. This company including ERP in Germany and DATE in France, and Simply Medical in England, and MST in Czech Republic. All the manufacturers use nitrous oxide as cryogen except for MST, which used liquid nitrogen. For ERP, cryotherapy system is approved by FDA to use in United States. And a flexible bronchoscope with a working channel of 2.6 up to 3.2 millimeter is required to use with a flexible cryoprobe. And the cryoprobe should keep about 4 millimeter away from the bronchoscope tip to prevent freezing of the camera of the flexible scope. Cryotherapy is currently used in two different ways. The first way is standard cryotherapy. Step 1. Cryoprobe inserted through bronchoscopic channel and applied directly to the target tissue. Then press the foot pedal 3 to 7 seconds to freeze tissue contacted to the probe, followed by releasing the foot pedal to allow thawing frozen tissue on its place without removing the bronchoscope. Repeat the freeze and thaw cycle 3 to 5 times without removing the bronchoscope out of the patient. After 3 to 7 days, do bronchoscopy to remove necrotic dead tissue made by freeze and thaw cycles. The bronchoscopist nowadays, I'm preferring to use standard cryotherapy way, unless in special circumstances where other modalities like laser or electrocautery cannot be used. Second way, which is commoner, is cryo-extraction. Its steps include the cryoprobe inserted through bronchoscope channel and applied directly to the target tissue. Then press the foot pedal for 3 to 7 seconds to freeze tissue contacted to the cryoprobe. Bronchoscope is then removed with the cryoprobe and attached frozen tissue while you are continuing impressing the foot pedal. Then the frozen tissue is allowed to thaw. Once it is removed from the airway into the formalin or normal saline by release the foot pedal. This technique is needed using an endotracheal tube or rigid tracheoscope to facilitate repeated removal and reinsertion of the flexible bronchoscope. About indications of cryotherapy, The main indication is malignant airway obstruction, which has been the most common indication for cryotherapy. Also being used for obtained transbronchial biopsy to diagnose interstitial lung disease, and also being used to obtain endobronchial biopsy for bronchial tumor, and used for removal of foreign body. This is common in pediatric because children trying to discover the surrounding environment using their mouth. Also used for retrieval of mucus plug and blood clot and aspirated food matter. Also, cryotherapy used sometimes to treating granulation tissue formation in covered metallic stent, where other modalities such as electrocautery or argon plasma coagulation or laser are contraindicated. In this case, usually use standard way of cryotherapy, not cryoextraction. Next talk is about transbronchial lung cryobiopsy. Transbronchial lung cryobiopsy has been reported to have high diagnostic yield for adults with interstitial lung disease with limited complication. So it is an emergency technique to obtain lung tissue for diagnosis of interstitial lung disease. Before doing transbronchial lung cryobiopsy, correct any bleeding tendency. So check and correct patient coagulation profile. Any deficiency in platelet count should be corrected. Stop any anticoagulation therapy prior to operation by 12 hours, such as heparin or low molecular weight heparin. And warfarin and clopidogrel should be stopped 5 to 7 days prior to procedure, while aspirin in general allowed to continue. Transbronchial lung cryobiopsy should be performed in operating room under total intravenous anesthesia via a rigid bronchoscope or endotracheal tube. Using, in case of rigid bronchoscope, using a rigid barrel as a conduit for flexible bronchoscope. The instrument required to do transbronchial lung cryobiopsy include endotracheal tube or rigid bronchoscopy, deep sedation or general anesthesia allow better control of procedure and bleeding, and prophylactic balloon brokers should be used to tamponade any bleeding, and also to prevent overspill of blood from the segment that is being sampled. The procedure should be performed under fluoroscopy to ensure that samples are ideally obtained about 10 mm from the pleural edge. This is a picture including the main instrument requiring for transbronchial lung cryobiopsy. The steps of transbronchial lung cryobiopsy are 4 steps. Starting with step 1, and introduce Fogarty balloon through the rigid scope and place it into the target segment or subsegment using the balloon guide wire. Step 2, introduce cryoprobe through the working channel of the flexible scope into the target segment or subsegment using flexible scope. Step 3, under fluoroscopy guidance, taking lung biopsy using cryoextraction way. Step 4, inflate the Fogarty balloon for 2 to 4 minutes in place of biopsy to tamponade upcoming bleeding. This case was in Malaysia during my interventional pulmonology fellowship training. It is not a typical case of interstitial lung disease, but the steps of transbronchial lung cryobiopsy is the same. The case belonged to 63 years old male with left upper lobe mass surrounding by granulous opacities. This is narrowband image to see vascularity of the mass and surrounding mucosa before doing TBLC. A transbronchial lung cryobiopsy is alternative to surgical lung biopsy with fewer complications. The reported complications include bleeding and pneumothorax and bronchospasm.